Prostate cancer is the most common tumor in men. The American Cancer Society estimates that 220,800 men will be diagnosed with the disease in 2015. According to standard medical theory, prostate cancer typically turns deadly after tumors stop responding to drugs that block the production of testosterone and its receptors. Therefore, for years, urologists have treated prostate cancer by decimating a man's testosterone levels, a treatment that is formally known as androgen deprivation therapy. Medical school taught that this was the holy grail of stopping prostate cancer dead in its tracks. A common treatment for prostate cancer is chemical castration, drugs that cut the body's production of testosterone and related hormones. The fact that this treatment often resulted in hellish side effects was either ignored or rationalized by the depressing mantra of, "At least he's still alive." So on and on it went. Men were forced to choose between death by the spread of cancer or losing their manhood and all of the horrifying consequences that went with that loss: sexual dysfunction / impotence, hot flashes, joint pain, loss of muscle tone and strength, increased fatigue, and a sense of hopeless depression. A new study shows that the exact opposite of the standard treatment may be far more efficient in combating prostate cancer. In this study, testosterone replacement therapy, or TRT, which increases a man's testosterone levels, was shown to slow the progression of untreatable prostate tumors in some patients. The hormone testosterone, which supposedly fuels prostate cancer growth, unexpectedly blocked the disease in certain cases, according to researchers who found it made tumors more vulnerable to treatment in some patients. This finding came as a shock to many, and the race was on to discover how and why this unexpected result was happening. To some, the traditional approach of lowering testosterone levels to stop prostate cancer defied common sense. It is a known fact that young men are flooded with testosterone, but young men are very seldom diagnosed with prostate cancer. As men age, beginning around age 30, testosterone production begins to decline at a rate of approximately 10% per decade. So do the math. This means that an 80-year-old man has around 50% of the testosterone that he had at age 30. But which age group is being diagnosed with prostate cancer? The 80-year-old men. This begs the question: where in the world did the idea that annihilating a man's testosterone levels would prevent prostate cancer from spreading? The connection between average to high levels of testosterone and prostate cancer was first promoted in the early 1940s by Dr. Charles B. Huggins, a Chicago urologist. In researching benign enlargement of the prostate, Huggins experimented with castration of dogs, the only other species besides man that suffers from prostate problems. Huggins noticed that after castration, the dogs experienced shrinkage of the prostate. And when their prostates were removed, no more cancer. This removal led to Huggins trying the same thing on humans. It was known that castration reduced testosterone levels in the bloodstream. He then took a group of men whose prostate cancer had spread to their bones and lowered their testosterone levels, either by administering estrogen or castration. Also, a blood test called acid phosphatase was elevated in men with metastatic cancer that spreads outside the prostate gland to the lymph nodes, bones, or other areas. If the testosterone levels of the men were lowered, acid phosphatase dropped considerably, usually within days. Taking it one step further, Huggins made the shocking discovery that raising testosterone levels caused acid phosphatase to rise and also resulted in, quote, enhanced growth, end quote, of prostate cancer. As a result of his work, Huggins was awarded the Nobel Prize in 1966 for determining that prostate cancer grew or shrank depending on testosterone levels. More important, this became the only officially approved method of treatment for prostate cancer and has been mostly unquestioned until recently. These accolades were bestowed upon the good doctor in spite of the fact that in his study, only 3 men had received testosterone injections. But the results were only given for 2 of them, and 1 of them had already been castrated. Therefore, the results were only for a single man who had received testosterone injections with any prior hormonal manipulation. Most studies are ignored unless they have several thousand participants, but not this one. No one checked the numbers. Believe it or not, this was the study that somehow became unassailable dogma to generations of urologists and condemned countless victims to a lifetime of needless suffering and misery. It was noted that after androgen deprivation therapy, cancer cells usually adapt to the low hormone levels and resume growing. For example, they sometimes crank out more of the receptor molecules stimulated by testosterone or switch to a version of the receptor that doesn't need testosterone to prompt growth. Although researchers have devised new treatments to counteract this resistance, such as drugs that block the testosterone receptor, tumors often quickly develop resistance to them as well. Studies of cancer cells in a dish and tumors in animals have discovered a paradox about so-called castration-resistant prostate cancer. Cancer cells that expand when testosterone is scarce often die when exposed to high levels of the hormone. Experiments suggest that the extra hormone interrupts DNA duplication and leads to DNA fractures, which can kill a cell. This paradoxical relationship means that testosterone doses could be beneficial against resistant tumors. Medical oncologist Michael Schweitzer from the University of Washington, Seattle, and colleagues from the Johns Hopkins University School of Medicine in Baltimore, Maryland, put this idea to the test. In a trial of 16 patients, investigators used a new method dubbed, quote, bipolar androgen therapy, end quote, to attack tumors that had built resistance. Patients were given monthly testosterone shots while simultaneously receiving drugs to block its natural production, creating huge swings in levels of the hormone. Most of their tumors had spread or metastasized. In the study, the men continued to receive chemical castration therapy, but every 28 days, the researchers also injected them with testosterone and 2 weeks of a chemotherapy drug called etoposide. Men who showed decreases in PSA levels after 3 cycles were continued on testosterone injections alone. Each shot spiked blood testosterone levels well above normal, but they gradually declined until they were close to the level produced by chemical castration. The rationale for these oscillations, Schweitzer says, is that, quote, you don't allow prostate cancer cells to get accustomed to one testosterone environment, end quote. The hormone peaks will kill cancer cells that have adapted to low testosterone, whereas the valleys will smother cells that require testosterone to grow. Of the 16, 2 did not complete the study. 1 died of pneumonia and sepsis due to the etoposide, and the other experienced prolonged erection, a side effect of the testosterone. Of the 14 remaining in the trial, 7 experienced a dip in their PSA levels of between 30 and 99%, an indication that their cancers were stable or lessening in severity. 7 of the men showed no decrease in PSA. Besides, 4 of the 7 men stayed on testosterone therapy for 12 to 24 months with continued low PSA levels. Of 10 men whose metastatic cancers could be measured with imaging scans, 5 experienced tumor shrinkage by more than half, including 1 man whose cancer completely disappeared. Quote, the fact that half of the guys who got through 3 cycles, end quote, of treatment quote, showed a response is encouraging, end quote, Schweitzer says. Surprisingly, we saw PSA reductions in all of 10 men, including 4 whose PSA didn't change during the trial, who were given testosterone-blocking drugs after the testosterone treatment, end quote, says Dr. Samuel Denmead, the senior author of the paper and an oncologist at Johns Hopkins Kimmel Cancer Center in Baltimore.